Asmita, shall I start? Yep. Okay, good evening to all of you. Can you see my slide?
Yes, sir.
Yeah, right. We'll start with the first happens to be a long case, then comes the short case. So this is a story of a 60-year-old male patient. His complaint started 1 week back as diffuse headache, spreading from vertex to occiput bilaterally, associated with 2 episodes of vomiting. Headache subsided in 3 days' time. 2 days later, patient noticed imbalance while walking. There was mild dysarthria. This was a leading question. Complaints have been progressive since then, in that you took longer time to walk for the last 2 days. No history of any fever, no history of any upper respiratory infection or diarrhea prior to the present complaint. So this is a story of a 60-year-old male patient. Complaint started 1 week back as diffuse headache spreading from vertex to occiput bilaterally, associated with 2 episodes of vomiting. Headache subsided in 3 days' time. 2 days later, patient noticed imbalance while walking. There is mild dysarthria on leading, which is on leading question. Complaints have been progressing since then, since that it took longer time to walk for the last 2 days. No history of any fever, upper respiratory infection, diarrhea prior to the present complaint. And patient was not a known diabetic. This is why he came to my room and he walked into my court. He walks very slowly, gently wide-based, and similarly ataxic also. He was very cautious in his walk. Examination pupils were normal. The extraocular movements were also normal. Korean mind is slowing, not very convincing. But he had bilateral orbicularis oculi weakness. He's also got bilateral facial weakness more onto the right side. He's got bilateral occiput buccinator weakness. Cannot whistle properly. He had also got right-sided palatal weakness. Palatal is going towards the left side. Tongue movements were quite normal. Sternum power was normal. Hand grip was normal. Proximal upper limb muscles power normal. Had no finger nose incoordination. No incoordination. Lower limb tone was normal. So also power was also normal in both proximal and distal muscles. Dorsal power normal. EHL, FHL were also normal. Panda pressure normal. Reflexes, upper limb reflexes are just elicitable. 1+. Lower limb triceps also elicitable normally. The knee jerks are normally elicited, but angle jerk on the right side is absent even after reinforcement. Left angle jerk just 1+. A recheck with reinforced still is absent. Abdominal reflex intact. Randar mute. Examination pain sensation normal throughout. Vibration. So also lower limb also vibration is normal. Johanson's also normal in upper and lower.
ഇപ്പോഴേ അതേമാതിരി ഇപ്പോഴേ
He said correctly in the upper limb.
വെരി ഗുഡ്.
So also lower limbs also he said correctly.
ഇപ്പോഴേ ഇപ്പോഴേ ഇപ്പോഴേ
Then normally. It's also
ഇപ്പോഴേ
normal.
ഇപ്പോഴേ ഇപ്പോഴേ ശരി.
Heel shin was slightly abnormal and both lower limb.
ഞാൻ കറക്റ്റ് അവിടെ കൊണ്ടുപോവാം.
Right, incoordination is there, the heel shin test. Not a gross, very mild incoordination. Neck muscle power was normal. He is made to get up from lying down, sit awkward position. Let's see how he is walking. Thrombus is positive. He could, even with also eyes open, is slightly wobbly. It is aggravated by eye closure. This is how he walked. Tandem walking was grossly defective. Okay, these are the findings. Cranial, second cranial normal. Extraocular movement is normal. Curry miles, so I'm not convinced about it. But what is definitely is bilateral LM and facial weakness, right more than the left. Right partial palatal paralysis. Rest of the cranial is normal. Now, motor system, tone power normal in both upper and lower limbs. DTR, upper limbs, all upper limbs are just sensitable. Lower limb, both knee jerks normal. Right angle jerk was consistently absent, left normal. Abdominal fluid is normally elicited. Plantar both indifferent. Sensory system all normal. Stands mild imbalance on standing and walks slowly with broad pace. Tandem walking was impaired. Cerebellar signs, finger nose incoordination is not there, but heel shin appeared mild incoordination in both the lower limbs. So, this is any clarification on the findings? Please ask me. So, where do you think is the localization, possible etiology, diagnosis in this patient? Bilateral LM and facial, right palatal weakness, power normal, DTR right angle absent, others are just sluggishly present. And then sensory system entirely normal, heel shin mildly positive, and get ataxia and tandem walking positive.
Sir, one doubt, sir. Patient had a headache.
Yeah,
before
he
the
headache
onset.
right. At the onset, patient had headache, and the headache subsided with vomiting. The headache subsided in 2-3 days time. Subsequently, no headache. Only at the beginning of the illness, he had headache.
So, since the patient has a bilateral LM and facial palsy with the ankle reflex loss in both ankles.
No, only right is absent, left is present.
Left is present. Okay, sir. Still, we can consider multiple radicals, sensory and motor radicals, with the prior onset of fever, prior febrile illness. We have to consider GB syndrome, MFS spectrum diseases.
Okay, a very good possibility. Very good. So that's a possibility you have to keep in mind. But usually, he have got ataxia, reflexia, ophthalmoplegia. None of them is present. Only seventh palsy is there. Okay, to call ataxia, okay, that's a possibility. But then it's not classical presentation, no? There's no classical triad is only right angle check is absent, left angle is normal.
Yes, sir.
And
MFS
also-
syndrome, sir.
Sir, can we call it a
please go on.
sir? Can we call it a GQ1B syndrome?
Yeah, and the
Or
GQ1
overlapping features of all.
That's exactly the other doctor has also told that it's a combination of Miller-Fisher GBS overlap syndrome. Same as. Okay, that's a diagnosis we all keep. Okay.
So another possibility to consider can be intramedullary, at the pontomedullary junction.
But okay, that's a possibility which can explain the ataxia and seventh nerve involvement. Okay, but there is no other, only ataxia was in the lower limb. And there is no incoordination in the upper limb, no cerebellar that may not be there. Okay, that possibility also can be kept in mind.
Any vestibular nuclei involvement can give the attacks, no, sir.
Yes, that's also a possibility. Bilateral, but nuclear involvement bilaterally without symmetrically occurring, without vertigo, it's odd. Because usually bilateral vestibulopathy can produce definitely ataxia, but they don't produce a Healshin positivity. But you can argue the Healshin positivity is quite mild if at all is present. So in that sense, you are right. Because bilateral vestibulopathy can produce gait ataxia, tandem walking deficit, but no limb incoordination. Here, the limb incoordination, no limb is questionable. That way you can say.
So onset is with headache and vomiting.
A headache, that only, but subsided in 2-3 days time. Correct.
Vertebral base has stroke.
A stroke, but we see bilateral seventh nerve in a stroke. How do you explain that? Moreover, no other brainstem signs or symptoms except for the gait ataxia. Bilateral seventh nerve is very odd in a LM7 is odd in a stroke patient without other things. Okay, let us analyze the problem. So, what is definite is bilateral seventh and right tendon palsy. There is also ataxia. There is no question about that. Now, what is the site of lesion for the ataxia? That's the first question. These are the three sites of causing the ataxia: cerebellar, sensory ataxia, bilateral vestibulopathy. So, is it cerebellar to cause ataxia in this patient? Yeah, no nystagmus, no upper limb incoordination, lower limb incoordination there, which can go with anterior vermian lesion. Yes, possibility. Was it a sensory ataxia?
No.
And why? Because there's no sensory loss. Correct? You're right. But its right angle check is decreased, absent. There was a point favoring
vibration and everything is normal. So vibration
normal. You're perfectly right. Vibration is normal, joint position is perfectly normal. Still is ataxic in the lower limb. Okay, again doubtful. What is bilateral? We guess already bilateral seventh nerve, no? So why can't be a bilateral vestibulopathy?
He sways even with his eyes open on standing. Vestibulopathy usually with the eyes open they can stand.
No. Even bilateral vestibulopathy with eyes closed, it will be worsening. You can have mild ataxia and tandem walking can be defective in bilateral vestibulopathy. It will worsen with eye closure.
What is the head impulse test?
Okay, so that is the you wanted to do. Okay, let us come to one by one.
The test is not abnormal bilateral vestibulopathy.
But I didn't get you, please.
A knee heel test is abnormal in this patient. That can't be possible in bilateral vestibulopathy.
That's perfectly right. Yeah, what is it is correct. But the question is, was it really positive? We are not very sure. Because he has mild, I also thought he has got incontinence in the lower limb. But one can argue, many people sometimes there's mild, this thing can be seen normally also. If it is, that's a good point. If it is there, that is against. But yeah, I'm not very convinced about the abnormality here. That's the problem. So that possibility has to be kept in mind. If it is definitely there, I would have agreed with it. It's not vestibulopathy. Okay, so what investigation do you need now?
Brain, sir. MRI brain, sir.
Okay, MRI brain. So already patient came with an MRI brain. So this is the MRI brain. This is the flare sequence. Normal. There is no hyperintensity in the brain. This is the T1 weighted. This is SAGE. This is a sequence showing the cranial to find out cranial abnormality. This is the medullary level. Then pontine level. upper pons, thin cut at the level of seventh nerve. That is the fifth nerve. Then it's that's level of fifth nerve. So grossly normal. So what do you want now?
So can I see the medullary level cuts again?
This is a sag cut. This is the axial C sequence showing the medulla. This is the upper medulla and lower pons. This is the mid pons level. At the level of lower pons and mid pons. This is the upper mid pons showing the fifth nerve. The other was seventh nerve level. Seventh and eighth nerve level. This is the fifth nerve level. So, how will you proceed further in this mission? What do you want? So, no obvious cerebral lesion is seen. That much is certain. No brain lesion is seen. To account for that here.
CSF and nerve conduction. Sir.
Nerve conduction. So, you want contrast MRI?
Yes, sir.
Because why? Because it's got seventh nerve involvement, no? So we want to know whether there is a enhancing nerve in this patient. Because we are not, we did not find anything in any lesion then compressing the nerve also. So this is a contrast MRI was done. Look at the contrast MRI. There is no obvious meningeal involvement. Considering only the posterior fossa region.
Sir, I'm not sure, but the fourth ventricle is showing something, I think.
Let me see the fourth ventricle once again. Normal only. No gross abnormality in the fourth ventricle. Moreover, we don't expect anything in the fourth. Clinically also, we don't expect anything.
Yes.
Yeah. Okay. So there is a 3D sequence for contrast. You can look upon the finer sequence to find out enhancement of the nerve. And look what is happening. Did you see the enhancement of the seventh nerve there going to the costic meatus? I will show the cut again. This is the enhancement of the seventh nerve bilateral. That too. So I'll show this is an enhancement of the seventh and eighth nerve complex bilateral. But there is no enhancement of the 10th nerve seen, even though it's got a partial 10th nerve involved. So showed no enhancement of both seventh nerves, no cerebral dilation. Now what will you do?
NCV and CSF, sir.
Okay. NCV with what idea in mind? That's the question.
Could it be radiculopathy, sir? GV
Yeah, right. GVS syndrome, I think. Okay, that's very good. Then there's another Paul. Yes, already got bilateral seventh nerve. So seventh and eighth nerve complexes go together. No, there is enhancement. There can be a bilateral vestibulopathy, as Dr. Bitch was pointing out. So any other test you would like to do to find how to rule out bilateral vestibulopathy?
Head impulse test.
Okay, so head impulse test. This head impulse test is done. I'll show you. It is negative. Head impulse is normal. There is no evidence of any bilateral vestibulopathy. So one thing we excluded bilateral vestibulopathy as cause of ataxia. So could it be, next question is ataxia to sensory ataxia? So if you want to rule out any, so NCS. This is NCS. The amplitude of the peroneum was decreased bilaterally, motor contraction. TA pickup is good, TBL pickup is good. Mean upper limb is also normal, that we are not interested in. Okay, the conduction velocity is 42, 45, normal range. Upper limb conduction normal. Now sensory all normal. FAV latency normal. So conduction is normal. Now, what do you think now?
FA morphology, sir.
Pardon?
The morphology of FA is any temporal dispersion.
Okay, very good. That I got that picture, but that is normal. FA, there is no chronodispersion, no impersistence of the FA, or there's normal FA we see. That's a good thing you thought about. Because someday FA latency may be normal, it may be the only abnormality in the chronodispersion or the FA persistence to show as evidence of a demyelinating involvement of the motor nerves.
Still could be GB, sir. CSF.
Yeah, you want CSF, okay. No, let's analyze one by one. CSF is for finding the cause of it. What I'm trying to find is what is causing the ataxia, site of relation for the ataxia. That is the first thing is in a neurological approach, you have to localize where it is. Then you do investigation to find out what caused it is. So we know the surgery is due to some inflammatory lesion and some that, but we don't because we have documented something. We excluded vestibulopathology as a cause of ataxia. We restricted to be cerebellar ataxia. Sensory ataxia, there is no sensory potential abnormality. No, what else will you do? Okay, the only abnormality in the lower limb are absent right knee check with mild lesion positivity. Snaps are normal. So can be lesion in the sensory roots now.
Can be an abnormality in the dorsal root ganglia, like in Miller fission also.
Yeah, there can be root lesion right proximal to the ganglion. So snaps will be abnormal only if the lesion happens to be in the ganglion or distal to that. Right. And if lesion is proximal to the sensory root, you will have a normal snap.
So CASP like picture, sir.
Exactly. CASP like picture. So what will you like to do in this patient? Is the angle check is absent at the same time.
SSCP.
SSCP or H reflex, correct. So in the test, sensory adiculopathy since angle check is also absent. So H response was done. H response is normal. You're back to square one. So is there any other way ataxia can be explained? That's next question. No sensory loss in this patient in the peripheral nervous system, but angle check happens to be absent. Second thing, he's not a diabetic. He has got no vestibular lesion, no cerebral lesion. Still, we are explaining why he is ataxic. That's the problem. Okay, this I'll let us take the situation. Pardon?
Within the
Pardon?
spindles, within the
Pardon?
muscles.
Exactly. Yeah, exactly. That's the thing I was saying. So let us take situation of Miller-Fisher syndrome. What is causing ataxia in Miller-Fisher syndrome?
Muscle spindle.
Yeah, exactly. The upper of the muscle spindles. So such Miller-Fisher need not have sensory loss at all. They can have absent reflex, reflexia, but sensory may not be entirely normal because the affection is not in the afference from the periphery, in the skin or joint cells. It is in the muscle spindles. See the picture from the Fisher syndrome. You can see this is this is the antibody, GQ1 antibody, where it's located. In the muscle spindle here, that is causing the ataxia. That will not be picked up in either SNAP or H reflex. Okay. So this is coming with the muscle spindle. H reflex is distal to that. The muscle spindle will not be picked up in H reflex. And this is forgettable. This is not relevant anyway. The myoclonus is also due to antibody attacking the neuromuscular junction in the globe, in the eye, as well as reticular forgettable. This happens. So this is the site of lesion for the attacks in Miller-Fisher syndrome. So that's a possibility here because he has got absent angle check. There is one indirect evidence to say that, but we have to explain the attacks. Okay, so is it a Miller case of Miller-Fisher overlap syndrome? Now, what other tests you need?
Anti-GQ1.
Antibody test.
Anti-GQ1 and CSF also, no? So
Yes, sir.
CSF showed, 58 cells, lymphocytes, and CSF is this is not 945, it's only 94 because it is reported as milligram per liter, not deciliter. So actually the protein value is 94.5, glucose normal. The blood parameters ESR is also normal. Now what else you need now? CSF is showing elevated protein and mild lymphocytic pleocytosis with the normal sugar. Can go with Miller-Fisher syndrome or inflammatory radiculopathy. You already said the antiganglios antibody, they were all negative. GQ1 BNM negative. Now, other things we have to find out what is causing the enhancement of the nerves. That can occur in Miller-Fisher syndrome due to inflammatory lesion, but we have to also rule out other causes also, like sarcoid, lymphoma, etc. So these tests were a CSF age level was done, that is normal. I want to rule out any underlying malignancy causing is a paraneoplastic syndrome, like US abdomen, CT chest abdomen, all normal, they're all normal. Now, what will you do now? So we have reasonably think that more likely to be a Miller-Fisher GBS overlap syndrome. So I repeated the NCS, okay, because we have to confirm whether it's really NCS GBS or not. So this is second NCS done. This is initially the velocity is normal. Now it has decreased on the second NCS after 5 days. Sensitive potential remain normal, HbF remain normal. See, this is the previous value. See that this value is 38 and 39. The previous value was 40 and 44. The second value in the tibial nerve was 38 and 37. Initially it was 40 and 41. So obviously there is some involvement of the conduction in the periphery. So we are now certain it's most likely to be a Miller-Fisher variant syndrome or a GBS Miller-Fisher overlap syndrome. So patients put on IUAB for 5 days. And following after 5 days, his patient did not improve, but he gait showed improvement. Remember the initially how he walked. His walking is much better. And tandem walking is still impaired tandem walking, but it's better than before. Okay, that's the story of this patient. Now, any questions? Now, the idea of bringing this case is if you find a person with ataxia, how to go ahead, proceed. The 3 things you rule out: vestibulopathy, cerebellar, and sensory. The sensory ataxia does not mean that it should be a sensory loss. That's the point. It can be due to loss of apparent input from the muscle spindles as in Miller-Fisher syndrome. That also you have to keep in mind. So any questions?
Bilateral CMAP reduction in the peroneal. How will you explain
Yeah.
that?
I do not know to explain that it's not a diabetic. See, the only way, retrospective, I'm not telling it is like that. If you only CMAP is reduced, we think of axonal involvement. But in a demyelination also can produce decreased CMAP amplitude because the demyelination or a nodopathy happen to be involved the distal part of the peripheral, distal to the site of stimulation. Suppose there is a conduction block distal to the distal part of the nerves, you can decrease CMAP amplitude demyelinating lesion. In nodopathy also, if it is affecting distal to the stimulating electrode, distal stimulating electrode, you can decrease CMAP amplitude. I'm not telling that is the first diagnosis. Usually you think of axonopathy, but under this context, since a patient develops subsequent conduction velocity abnormality, probably the decreased CMAP amplitude can be explained in that way.
When you do a nerve conduction study, it's a common finding. Most of the patients
Yeah, exactly.
will be expecting
Yeah.
some neuropathy. They'll be having
You're also right. Many a time you find a decreased CMAP amplitude in the conperonal nerve because maybe it is medium or something, but you do not have any of those things.
The cause of
I think
headache,
so.
sir.
Then if there is any inflammatory lesion in the brain can produce headache. You get inflammation of the seventh nerve, meningeal involvement that can cause headache. So that is why in the decreased CMAP amplitude, I did not give any significance initially also. That is the motor part. I am not bothered with we are not bothered with motor. What we want explanation for the ataxia. That decrease in CMAP amplitude will not cause ataxia. That is why I did not give much importance to the decrease in CMAP amplitude. As you see correctly, many normal individual can have decrease in CMAP amplitude because the edema or thick skin and all. It can be decreased. Headache can be due to the inflammation in and around the seventh nerve and the fifth nerve. And that nerves are enhancing.
Sir, can I ask a slightly unrelated question?
Obviously, anything you can ask, no problem. That's
Sometimes, like in early GBS or in acute myelopathy, like a cord contusion, in supine testing, the power will be grade 4 or something, but the patient will be very bedbound. When testing the gaits, patient will be unable to walk, but the supine testing will be disproportionately better.
Yeah.
In such situation, can we explain that finding as an ataxia or an axial weakness, which is better?
Okay. That's a good question. Now, this point has been many times I've mentioned in my examination. Whenever you want to say there is patient got a lower limb power is normal, when you examine in the lying down position, supine position, you get a normal power. Okay. But the ideal way to examine the lower limb power is to put the examine in their offending position, in the offending position, in their vulnerable position. So you say plantar flexion is weak only when the patient is unable to stand. It's normal only when the patient is able to stand on toes. And if the patient is not able to walk on toes or not able to walk on heel, then you can think that dorsal plantar flexion is weak. And the bedside, this muscle is very strong. No, you cannot overcome that muscle power with your hand. So always examine the offending position. Similarly, hip abduction also, when you examine the bed in lying down supine position, they may appear apparently normal. But when you patient lie on one side, examine against cavity, you can be the weakness. Even that may be normal, you have to do the tendril back test. And that will pick up the hip abduction weakness. And the most difficult thing will be for the corticeps. Corticeps is so powerful that you cannot mind weakness can be easily missed. The only way is that ask the patient to stand on a stool, then lift up one leg and to get up with the other corticeps. That will be weak. This I did not know earlier. Dr. E.G. Thomas only told me this technique, and that's a very useful technique. So always examine the lower limb muscles in their offending or vulnerable position. So
One
that is,
doubt. Can you
please.
repeat the quadriceps once again? Because quite
Yeah.
we hear they are having
Right.
weakness of the joint and buckling, but when we examine, power will be quite normal.
Very, very good. In fact, I had 2, 3, if you have seen my videos, I have shown 2, 3 cases I have shown you how I examine. I'll tell you. Ask the patient sit on a stool. Okay, not a stool. Then ask him to lift up one leg. That is at the flexed knee. Like knee is flexed. Lift up one leg at the thigh. Cannot straight away. Lift up the thigh in the flexed position. Okay, you got the point. Then he's only sitting with the other leg. Now hold on to ask him to hold on to your hand. Ask him to get up on one leg. The one leg is it is now put on the floor now. Ask him to put on the weight on that leg and to get up. That means he's getting it with only that one quadriceps.
Okay.
Other quadriceps is knocked off because he already made it lifted up.
Mhm.
Okay. Then do the other way around.
Okay.
Ask him to lift up and put the both together. Ask him to lift up the left foot and then ask him to get up on the right leg. Okay. Because God is so powerful that normally please.
Sir, in that case, will he be using his upper limb also to assist?
Yeah, he can take the upper limb, no problem. Even with upper limb means he's not giving a balance only for the upper limb.
Yeah. Because without upper limb, it will be very difficult also.
Very difficult. Normal also it will be difficult for you also to get up and walk.
Also, I just tried actually.
That's not possible. You have to give support to the upper limb. But he is not getting it with the upper limb. Upper limb is only for the support.
Yeah.
He has to have that lift up your knee quadriceps. Okay. So one more thing I was about to tell. I answered the previous question. So that's one point. So when you find supine power normal, patient may not able to walk about. This is the thing you have to look for examine in the offending position. Second thing, if you find the normal power and patient is not able to get up and walk about, think about it may be a pseudo weakness. One of the classical examples of pseudo weakness is proprioceptive loss. When there's extensive sensation may be normal, proprioceptive loss, the patient may not know where the limb is. So you make it apparent weakness on the lower. Time and again, suppose you want to check the dorsiflexion weakness again. Unless patient look into the dorsiflexion, you cannot, the power may appear pseudo-paralysis. Sometime back, I showed one case of CASP with the patient not able to lift up at all. Like that. But she had normal power. Only because she has total loss of purpose, even from the shoulder down, everything is lost. This is usually same ganglion neuronopathy or a CASP patients. Something like a pseudo-paralysis.
Okay, sir. Thank you.
Related question, shall I answer?
Yeah, please.
We have presently one patient admitted with weakness both proximal upper limb. 1 month duration proximal upper limb. Her NCP is almost normal. Clinical examination DTR is absent and proximal muscles are upper limb proximal and distal is weak. Lower limb is quite normal also. 1 month static history.
Okay. Now the sensation
was a element type and probably Guillain-Barré, but 1 month is relatively sudden onset. Lower limb is perfectly normal also. Only upper limb.
Yeah. So question is can be Guillain, but they have got areflexia throughout. Areflexia lost only in the upper limb or throughout?
Areflexia both upper and lower limb, but weakness is only in the upper limb.
It's a promifested type of GBS syndrome. See, GBS syndrome need not involve all the muscles. Sometimes it may be confined to few muscles. One of the classical example of that thing is the PCB variant. The pharyngeus.
No pharyngeal weakness.
I'll tell you. So that is the one variant. But it's all said and done. It all depends upon the severity of the involvement. Sometimes you can have a GBS with a minimal weakness and a reflection, they get over very well and walk about. The extreme end, he will have zero paralysis. So it's quite variable depending upon the antibody response. It's quite variable. Sometimes haven't you seen GBS only confined to the facial muscles? Only facial palsy with the reflexia? You have already seen. So something similar to that, it may be only confined to the proximal muscles.
Okay. Only upper limb and
Yeah,
lower limb.
yeah, that's well known. That's
And
it.
NCV also normal, sir. No.
Yeah, NCV, so again, no, time and again we find that NCV can be entirely normal in GBS. Why? Because the earliest abnormality in GBS is the FA latency prolongation, correct? Now, suppose you have got 100 fibers in the dorsal root or the nerve, not dorsal root, and the nerve. If 50% or 80% nerves are damaged, only 20% of the fibers are intact in the nerve root and in nerve root. If you do the FA latency alone, that 20% of the fibers will give a normal latency value. Got it? So we are not measuring unlike motor conduction, we are not measuring the amplitude or anything there. We are only measuring the latency. So the remaining 20% fibers will conduct normally and put a FA latency is normal. So in that situation, suspect GBS always look for chronodispersion and FA persistence. Chronodispersion means if you take the 10 potentials I picked up, one FA will be coming earlier, one may be much later, another little bit later. So it's all just like a patchy demyelination. It is coming at various times. That's called chronodispersion. Other thing is that out of the 10 FAs, only 3 are seen, 8 of them are blocked. But FA latency is normal. What you are measuring only what is the remaining FA, we are measuring the latency. The blocked FA latency we are not reporting. So usually in the nerve conduction, we should also go and see as somebody has pointed out, should look for in fact, I examined the chronodispersion patient. I didn't show that, so the only thing. That was not there in this patient.
So I will see the dispersion and get back to you, sir.
Pardon?
I will see the dispersion. I had not seen the dispersion. Only the latency was noted.
Yeah,
So
sometime back, I'll want personal case to you, don't worry.
okay, sir. Thank you.
Okay, right.
Sir, about the
Yeah, please.
Trendelenburg test, sir, about that.
Yeah.
If the patient's hip extension is completely normal, abduction in the lateral position also is normal. Only the Trendelenburg is abnormal. Then inference.
Yeah, if the positive Trendelenburg test does not always mean weakness. It can occur due to weakness or hip joint disease, in fracture of the neck of the femur, quadratus lumborum syndrome, all can produce positive Trendelenburg. But excluding that thing, if you find a positive Trendelenburg, indicates hip abduction weakness. That may be the only lateral examination also pure may know. If you do the Trendelenburg, because Trendelenburg, the whole body has to keep it, lift it up with other hip abductors. See, if you want to stand on one leg and lift up the hip, or ask him to lift up the leg, the other gluteus medius and minimus is to be strong enough to hold the entire right side of the trunk up. Okay, your hand power, this cannot compensate for that. So that is an ideal test for a hip abduction weakness.
Hip abductors are only gluteus minimus and medius. This tensor fascial data is also.
And tensor fascial data, 3 things.
All these are supplied by the same, different.
They are different. So, but gluteus medius is superior gluteal nerve, and correct, and the tensor fascial data also correct.
And the same now.
Sir, one related question. How common is the pyriformis syndrome, sir?
In fact, I only seen 1 or 2 cases, not very common. Not very common.
Recently, I had seen so many orthopedicians referring as pyriformis, but I was not very convinced. But so many.
I am also not very much convinced. Most of the turn out to be disc prolapse or root pain.
Yes, sir.
How will they present pyriformis syndrome?
They exactly same radiating pain on the sciatic notch, and there is one particular test to find out this pyriformis syndrome. I forget at the moment. I am not getting in my. I am not able to tell now. That is a positive.
Of the hip, sir.
Pardon?
Internal rotation of the hip will elicit
rotation, sir.
Correct. That's a way to do that.
They say there will be selective stretching of the pyriformis without stretching of the root and.
Right.
No, I have seen
internal rotation at the hip.
Yeah.
Yeah, right.
Internal rotation at hip.
If that will stretch the piriformis muscle. Yeah.
Okay, sir. Sorry.
Okay. Shall I go to the next case? Okay.
Yes, sir.
So, this is a story of a 54-year-old lady. History of vertigo, quote unquote. Everyone complains of vertigo only, while standing for the last 3 years. She said she will get dizzy on standing for a prolonged period of time, become less dizziness while walking. No other complaints. No rotary vertigo or vomiting. So once again, history of vertigo while standing for the last 3 years. She will get dizzy on standing for a prolonged period of time, become less on walking. No other complaints. This is the examination findings. Ocular movement is normal, kindness examination normal, power is normal, there is no finger incoordination. Lower limb power normal. There is no heels in abnormality, normal. This you may think it is abnormal, it's not really abnormal. Many people are able to do only that much only. The reflexes are all normal. Lower limb reflexes decreased. Angle check was also decreased. Absent. Panda downgoing. Sensations all normal. This is how he walked. Slightly broad base. Maybe due to knee jolts, some people orthodox also will walk like that. But tandem walking was defective. So on examination, KLS all normal, no nystagmus, septus negative. Tone low power normal in both upper and lower limb. DT are all normal except the diminished knee and ankle chair. Abdominal plus normal, plantar flexor, sensory all normal. Stands normal. Walks slowly with broad gaze. Tandem walking is impaired. So where is the site of lesion? What will you like to, what any other test you would like to do with this patient? Or investigation you want? Any clarification, the findings you can ask.
The broad-based gait, is there any valgus deformity, sir, in the knee joint?
Yeah, that's what I said. I also thought so. It's exactly mentioning the knee joint. This is also sometimes produce this kind of a broad base. We cannot call it broad base. Okay, yeah, what you said is correct. The knee, the feet is going a little outward.
Yes.
I'll show that. Yeah, so valgus deformity is there. Correct. I'll show once again. And before that. Whatever it is, it's broad base is there.
Yes.
Bifurcation joint and position sensor.
Normal.
Cerebellar then.
How is Romberg, sir?
Rhombus is negative. Rhombus is actually, I'll show the normal. It is mild imbalance is there. I'll show the rhombus. Sorry. When standing feet is imbalance. So somewhere or other I missed that part of the video. I'll be there. Okay, sorry. Rhombus also is very imbalance during rhombus test. Even with eyes open, she has got imbalance.
Yes. So well, rhombus, the trunk is moving or trunk is straight, sir, because it excludes functional also.
Yeah, that's a possibility is there. Functional aspect can be considered because there is no objective evidence of any weakness, sensory loss, or reflex loss in this patient. No nystagmus, septus negative. Okay, anything else you want to do, anyone?
Cervical also to be
Cervical
Any
lesion.
tremors on standing? Lower limb tremors?
Okay.
Any tremors standing?
Let us see. She became with the MRI brain normal. So what will you do? So as Feroz is telling, examine her legs while standing. Now see her while standing. She has got myoclonus, orthostatic myoclonus. So this is always keep in mind, people with orthostatic tremor and myoclonus, they will not give the history they got a tremor in the lower limb. They will only complain of imbalance while standing, on prolonged standing. Then the history also, if you look the history what I told, she has got imbalance in standing, which become less on walking. That is a typical of orthostatic tremor, orthostatic myoclonus. On walking about, it becomes less. Did you see the myoclonus? It is not a tremor because it's the frequency is less and large amplitude. Or this tremor, the frequency is more than 14 hertz. See that this is a jerky movements of the time. So primary orthostatic myoclonus.
Can we show it once again? Also, can we zoom it, sir? We are not seeing the movement.
Okay, wait a minute. Let me see. Just 1 minute. 1 minute. Can you see it now?
Now we can see. That
The thigh muscles are jerky movement. See that. You can look at the sari also. It's moving. Okay. So always look for tremor and myoclonus while standing. They may complain of only imbalance while walking. Now, how to prove the point now? So I did EMG from the right. I'll show the EMG of the right calf. This is the right calf. The sitting position, no activity. So I'm going to make a stand up. See the burst of activity coming. Burst of myoclonus. It's not a continuous burst of activity is coming. Now I want to compare with that. I did from the cordyceps. Cordyceps is not undergoing any myoclonus. So now here the cordyceps of the we take it stand up again. This is what we normally expect when you get the patient gets up.
only from lateral, sir.
Pardon?
Only from which muscle wasn't lateral, sir.
No, it just picked up any muscle, that's all. Find out the normal activity, that's all.
First time?
Pardon?
First time from which muscle you did that?
For the calf, got the calf.
Okay.
Now I'm going to the other. This is the one. Now this is the on the left side. Initially I did from the right calf. This is on the left calf. The right calf I can show one side. This is the right calf. The calf. See the best of activity. Now from the left calf, thigh was normal. Left calf. Just like the previous one, but a burst of activity coming in the middle. Just with the myoclonus. So see another similar case. This lady came with the complaint of jerky movements of the feet while bending. No problem. Penny. See what is happened to the legs on bending? It goes into jerky movements of the lower. When she gets up, this will not occur. Her complaint was when she walks, let's go into tremulous movement. This again orthostatic myoclonus while bending. So actually, this orthostatism is a misnomer because actually I've seen people having myoclonus even without orthostatism. Sometimes some people get only on squatting, they can get this kind of a myoclonic check. So while bending. Now this is another case from Neurology. Again, I will show this lady. Walking, she has no problem. On standing, see that how the legs goes into myoclonic checks. Here it is more prominent in the thigh rather than the calf.
Sir, what is the difference between orthostatic tremor and myoclonus?
Tremor is fast frequency, more than 16 to 14 to 16 hertz. Myoclonus is a lower frequency. I will show the orthostatic tremor later on, just one. See, the movements are very coarse, not like a tremor. It's irregular also. Coarse and irregular. Now, how is the same? I'm answering to your question now. How is different from orthostatic tremor? So this patient, 70-year-old man, presents history of heaviness of head and imbalance while walking, which became better after walking for the last 1 year. CNS normal except for one finding while standing, and EMG showed this finding. I'll show the examination later on. Listen to the sound very carefully. Make him stand now. What is the sound mimicking? Helicopter blade sound. Correct. That is a typical sound you see in orthostatic tremor, and the frequency is higher. And you don't put a needle, you can put a surface electrode also, you can get it. So this is a control patient who has no orthostatic tremor. I put the needle to find out what happens when you make patient stand up. This is what is seen in the control patient. Now, this is, I'll show some sound now. This is the sound of a helicopter sound. It's exactly what you heard initially, what the patient had. This is another helicopter sound. Now with that, go back to my patient and see the sound now. So that's it. So that's the story of the helicopter sound. So what is the diagnosis? Now I go back to the video. I not shown the video of the patient, what happens to him. He is standing. So always make him not only sit like that, stretch the legs also, look for the tremor. Sometimes tremor may appear only at that time. Extend it. I had another patient with the tremor appears only on extending. Now make him stand up. Unlike the previous one, here the tremor is very, it is not very obvious to see, but he has got, still you can make out the irregular movements of the legs. But walking is comfortable. Again, you can make out the tremor now easily.
വിടാൻ തോന്നുന്നു അല്ലേ?
Now, you said feel like falling.
ഒരു
Prolonged standing, it become more imbalanced.
ഇനി നടന്നോ? മതി.
Now, this look at this man. This is not my case. This is again to neurology. He's got severe orthostatic myoclonus and standing. Involving the lump, trunk as well as this thing. But he walks about, it becomes much less. To the extent of falling down. Walking is okay. That kind of a jerky movement is disappeared. Now, this is after treatment. He's standing erect without any myoclonus. Now, this case is a case of a Casper-2 antibody. So, this is another condition where you can have orthostatic myoclonus. This I have just actually picked out this finding when I was searching for the orthostatic myoclonus. So, I thought I will show the video also. So that's about, so the lesson I have to tell is that when the patients got imbalance while standing and walking, clearly ask for this particular point. When you don't find any obvious sensory loss or incoordination, before telling it's non-organic, consider this possibility also. Because many times we think, oh, nothing abnormal, we try to send it out. Keep this point in mind.
Sir, does
Yeah.
orthostatic tremor respond to any medicine actually?
Yeah, they both these conditions, not myoclonus as well, respond very well to clonazepam. And the clonazepam, you don't think that you're getting only 0.5 milligram. Some patients are receiving 2 milligram 3 times daily. And you may wonder, are they not get sedated? See, these people, they tolerate this clonazepam very well.
Sir, is gabapentin also useful, sir?
No, because they responded very well to clonazepam, so I did not try that. The literature also said clonazepam. For the tremor, I also had propranolol also, not for myoclonus. Myoclonus had only this thing. Levetiracetam may be useful. I have not tried. But they responded very well, no doubt about it.
So which muscles are affected, sir? Like myoclonus?
In the calf muscles. It is in the EMG also, when you picked up, I put the needle only in the calf. Then subsequently in the corticeps. Corticeps did not pick up the burst of activity.
In elderly also more than 70 or 75 years, we can try that much dose of clonazepam, sir, like 1 mg TID or.
And I'll tell you, this is highly variable. You may think that I am bluffing. One of my patients, Stipperson syndrome, was receiving 80 milligram of diazepam. 80 milligram of diazepam. Gradually escalate because it's not getting only because you got severe spasms. What can you do? You have to increase up to 60 milligram of liraglutide, baclofen, and 80 milligram of diazepam. With that, he is comforted. No more spasms. You have to go on increasing. No, what else can you do? So these people, tolerance is highly variable. Some people even 0.25 milligram clonazepam, they don't tolerate. Some people tolerate very high dose.
If they are tolerant, we can try increasing the dose.
Pardon?
If they are tolerating the dose, we can try go on increasing the dose.
They are increasing they're tolerated. These patients I have been putting increasing dose, they're very well tolerated. I'm not straight away going to start on 2 milligram. Start 0.5, gradually escalate to 2 milligram. Depending upon if they're comfortable at that time, I stop. So not stop, maintain at that level. Okay, shall I stop or go for one more short case?
Sir, if they are not tolerating clonazepam, any other drug we can try?
I think I should have, as told before, we can try other things which is decreasing the stiffness. Like you can take baclofen and gabapentin maybe I have to look at the search with the literature.
We had one patient sometime before. He responded very well to gabapentin, sir.
Gabapentin. Okay. So we can try gabapentin.
So then this is a peripherally induced movement disorder, sir.
Correct, correct.
Sir, one more short case we'll yes.
Yeah. Okay. And before that, no, this orthostatic tremor myoclonus is a misnomer, right? I can show 5 different types of position in which myoclonus is occurring. One patient, when the leg is stretching, he'll get that. Or when he changes the stool or change the chair, he will change the stool, shift back to the chair, he disappears. Another person with myoclonus occurring only in the Joy had one case when they get myoclonus when he stands only on the toes. So these are all actually they are to be called isometric tremor or isometric myoclonus rather than orthostatic. Because nothing to the orthostatic. Because in the girl I showed, it was only on bending, not person on standing. What do you call? Is it orthostatic? So they are all similar conditions. So the ideal term should be an isometric tremor, isometric myoclonus. Okay, I'll show you one short case. 34-year-old male, old case of cirrhosis liver with portal hypertension. Present with his complaint is slowness in walking for the last 1 year. Dysarthria for the last 6 months. No history of tremor, no obvious history of any weakness. No history to suggest any cognitive impairment. See, if you find actually very subtle finding, his speech almost normal, but he said it's not the same speech before. Mild dysarthria is there. Cranials are all normal. So he's got mild rigidity on the left upper limb, not on the right side. Power normal. No finger nose incoordination. Lower limb power normal. Reflexes were normal. Plantar downgoing. Sensations were normal. And he says, to me, gait appeared normal, but he said this is not the way he used to walk. He's become slow. Wife also telling this is not the way he used to walk earlier. But I definitely he's found some change in his walking. His speech also is mildly dysarthric. And mild rigidity on the left upper limb. So mild dysarthria, mild hypertrophy in the left upper limb, mild slowness in walking, all the deficits could be made up. So what do you think is likely to be having? Possibility?
Basal ganglia involvement due to hepatocellular.
Non-Wilson hepatocellular.
Okay, very good. And now let us see the MRI of this patient. Let's go look at the hyperdensity in the cerebri, internal capsule. The internal capsule again, going down. You can see the cerebri is hyperintense. Then look at the coronal cut. Hyperdensity along the pyramidal tract. See the wine glass appearance. This is the air again showing hyperdensity in the pyramidal tract. Not very clear, but T2 was much better. T1. Hyperdensity in the basal ganglia in the globus pallidus. You can find the hyperdensity. See the hyperdensity there. There's a typical finding in hepatic encephalopathy. I think I will skip some of the pictures. This is the diffusion. Again, you can find hyperdensity in the posterior limb, cerebri and all. In SWA, there is no blooming anywhere. So notice it's got a hyperintensity in the globus pallidus, hyperintensity to show hyperintensity in the crus cerebrae and internal capsule. It's a classical wine glass appearance. So what is the diagnosis?
Manganese deposition.
Pardon? Exactly what is it is all correct. Acquired hepatocellular degeneration. So this hepatic encephalopathy can have various types of abnormality. They can have MCP, hyperintensity. There are many things can occur in this thing. So it can include Parkinsonism, ataxia, chorea, as well as cognitive behavioral affective symptoms. The abnormal symmetrical hyperintensity in the globus pallidus T1 weighted MR. That's a classical picture. And the hyperintensity may extend to adjacent areas, including the caudate, nucleus putamen, and renal capillary capillum. Hyperintensity in the thoracospinal tract and T2 weighted player and DW sequence has been reported. These changes are attributed to vasogenic edema caused by astrocyte swelling, driven by glutamate accumulation from ammonia detoxification. This is from the literature showing the hyperintensity. This much of hyperintensity can occur in hepatic encephalopathy. It's also occurring subjacent to the pyramidal and motor cortex. Again, just like our patient, you can have hyperintensity here in the crus cerebrae and the internal capsule. These are the other causes of wine glass hyperintensity: ALS, Rett syndrome, osmotic dysmyelination, Krabbe's disease, NMO, hepatic encephalopathy. MCP hyperintensity is not specific for MSA, can be seen in Wilson disease, alcoholic liver cirrhosis, neoplasms, cerebrovascular disease, inflammatory and demyelinating disease such as MS and acute ADM, Fragile X syndrome, and toxic conditions like heroin and adrenoleukodystrophy. Okay, that's a short case. Everyone made a correct diagnosis.
Sir, one doubt, shall I
Yeah,
ask?
please.
The previous patient, that myoclonic jerk. We recently had 3 elderly patients, all presenting with something like a multifocal myoclonus, which appears normally in the end-stage renal disease-like presentation. But they all presented with all in 80s, presented with fever, with total count normal, urine normal, everything normal, but high fever with multifocal myoclonus.
These patients underlying renal disease, no?
No, they were hypertensive, diabetic, but well under control. And all appeared, all 3 patients admitted in around in 1 month time only. Admission time, they all have severe myoclonus, cannot even stand by themselves.
Yeah, that's most likely an obstaclonus myoclonus syndrome.
But
see,
fever and no other complaint.
Yeah, that's what I'm like.
Total count, everything normal, and they all with a small antibiotic and a steroid because nothing else to be given.
Yeah. So usually, if you get a multifocal myoclonus, a severe degree, as you say, unable to stand also. And this comes under the spectrum of obstaclonus myoclonus syndrome, post-infective. They need not always have obstaclonus. They sometimes have eyelid myoclonus only. Sometimes I get one case only eyelid myoclonus with extensive myoclonus of the body. So that is what I can think when the patient fever followed by extensive myoclonus without any other metabolic abnormality.
No other.
Yeah, because this is a variant of an obstaclonus myoclonus. They improve with steroid. They improve sometimes may not with the treatment also they.
Yeah, one patient then again 6 months later again admitted. That time again severe myoclonus, but then later on improved completely.
But I don't. In that case, it's something other metabolic factor has to be ruled out.
Maybe, but first presented at the age of 80s. Since till then, other complaints and whatever available, ABG was normal. There was no acidosis, and available routine were all normal. And they all improved after 2 to 3 days of admission.
There, LFT and glutamate.
LFT was normal, sir.
No,
LFT was normal.
the problem with the problem is sometimes the ideal test to find out hepatic encephalopathy is a glutamine level, which we can't do. Many times that goes unmasked. Only abnormality may elevated serum, globulin level. So sometimes it can be missed like that. I don't say it is like that. There are the possibilities you have to keep in mind.
Okay.
Okay.
CSF glutamate level, sir. CSF.
Serum glutamine, that is the ideal test for hepatic
Serum or
encephalopathy.
CSF? Serum or CSF?
CSF.
CSF glutamate.
Yeah. Okay, shall we stop?
Yes, sir.
Yes.
Yeah.
Okay.
Okay.
Thank you, sir. Thank you very much, sir.
Thank you, sir. Thank you, sir.
Thank you,
sir. Thank you, sir.
Thank you. Good night. Good night. Good
Thank
night.
you.
Good night. Good night. Thank you. Good night.
Thank you, sir.
Thank you. Thank you. Good night.